Welcome to the Beyond Pain podcast with your host, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense. Welcome back into the Beyond Pain podcast. I am one of your hosts, Joe Gambino, and I'm here with our other host, Joe LaVacca. You can find us on Instagram at Joe Gambino DPT for myself and at Strength and Motion _PT for Dr. LaVacca over there. Podcast is also on Instagram, Beyond Pain Podcast, and on YouTube as well, Cups of Joe _PT. And Joe, I don't think we've ever asked this before of our listeners on this podcast, but a review would go a very, very long way for helping this podcast now. So if you have 2 seconds, please drop us a review. It's been a while since we've had one. Welcome back, Joe boy.
Thank you for adding that, Mr. Gambino. That was a good idea.
It only took us over a year to ask for one.
Yeah, exactly. So and it surprisingly does really help. And I say this to clients all the time in the clinic when they do have a good experience, or if they've been enjoying care or programming or training or whatever. Yeah, Google really appreciates, and Apple Podcasts and Spotify, they all really appreciate good reviews. So, yeah, I think that's
a way to help the show, and a way to help hopefully one more listener tune in and get a little help if that's what tends to happen there.
Yeah.
All right. Well, we have I think this is going to be a fun episode here. We have all about assessments, self-assessments, and I'm just going to let you kick it off with why don't we do this, Joe? Because I'm actually curious, maybe over the last year or few years, has anything changed with your assessment process?
I think that for the most part, my assessment process as a clinician keeps getting simpler and simpler. Yeah. And it probably is because over the last 5+ years or so, where I've really gone and focused the practice or the messaging on Instagram and what I like to teach is more around this idea of like persistent pain, or chronic pain is probably the more accepted term, or term that people most readily kind of connect with. And with chronic pain, problematic pain, persistent pain, there really isn't any one marker to just point to and say, aha, this is the reason why you have pain. And quick example for people listening would just be, hey, if you and I roll our ankle and we have bruising and swelling and we tore a ligament on the side of the foot, well, that's probably going to be a good enough reason why we're in pain. So we can point and say, here's a trauma, here's the tissue that's been damaged, this is why you have pain, this is how long we can expect pain, and we can kind of move on pretty quickly. But with a lot of problematic pain, it's tough, it's nuanced, it's layered. And by the time people have gotten to us and gotten to you, I'm sure too, they have x-rays already, they have MRIs already. There's so many people, including this week, talking to me about their hip shift or their leg length discrepancy or their posture. And again, we've talked multiple times how all these things can be factors. But I think the biggest thing that a lot of these complicated assessments do for people is they push them into this bubble of underloading. Well, I couldn't possibly squat if my leg length discrepancy is off by a half an inch or whatever the case is. I couldn't possibly bench press because my posture is already, so terrible that if I keep bench pressing, I'm going to just turn myself inward more on into my body, or into that, kind of slouched position. I think that's everyone's sort of fear. So really with my assessments in the clinic, I just want to make sure that you're safe to load and safe to move and you belong here. And that's, I think, the biggest thing with problematic pain is just making sure, hey, are there any red flags that we miss along the way? Because they are so rare that, I'm probably guilty of this too, that I, neglect them a lot of the time or think about them. But we should probably be starting there, ruling out some red flags for people. Then once we can kind of rule out red flags, I like really straightforward assessments that people can understand and almost follow along with. And I found it even helpful to speak what I'm doing, not only for my own benefit, but it slows me down and it kind of keeps the client engaged. So my assessments, if there has been a change, they've gotten simpler and simpler and simpler. And I always remember saying this when I was teaching, which I completely disagree with now. So maybe this is a 10-year switch, but I used to tell a lot of the people that came to the course for rock tape and everywhere else that, the clinical history was so overrated,
Mm.
that people were not good storytellers, and, a couple of questions about them is fine. And then get into your movement assessments, because that's going to tell you more than what you need to know. And now I'm like, yeah, I probably felt that way just because I wasn't asking the right
Right.
questions to people, right? And now the cool thing is when you kind of chat with people, you're almost sort of somewhat certain of a diagnosis even before you start watching them move or getting your hands on them. And I think that is the beauty of the listening aspect.
Mhm.
So that would be the biggest change for me. I'm sure there was lots of changes for you because we were all in person and then now you're all virtual. So I'd love to hear where your thought process went with that switch.
Yeah, I'll say before I dive in there, two things. I mean, I think you hit the nail on the head. Not good storytellers and like, oh, the history is overrated. It's just, yeah, I think if you think that way, one of the things would be you're not asking the right questions for sure. I found that when you ask the right questions and you really start to dive into it, your assessment almost becomes ruling in or ruling out your hypothesis. That's how I think of it in my mind. When I'm going through an assessment process, and I'm listening to somebody, I'm like, okay, well, I'm starting to think it's this. So I'm going to start asking questions to see if I can kind of confirm this. And then once I'm pretty certain it's this, then when we get to movement, okay, does the things that we're doing from a movement perspective match up to what I think it is? And if it doesn't, then I have to start to re-question and maybe probe in another way and see if I can get something to make sense. And if it's something that never makes sense, then usually those are the cases that you're referring out anyway, right? So I think that was really interesting to say there. And then on your note of underloading with how most PT things happen, you're saying rehab, this chronic underloading is an issue. And I find this interesting because I've been finding myself saying a lot of time to people, especially people who are interested in it with working with me, is that fitness, like you almost need to get away. If you've been in like chronic pain for so long and you've done rehab and you've had all the imaging and you've had surgeries and like you're still in pain, sometimes the missing link is just starting to get back and doing the thing.
Yeah.
Right. That this you just need to be pushed a little harder. You need to build the confidence. You need to start doing the thing, and we can do this safely. And that's where like the assessment and asking all these good questions really comes, because it gives you that picture, that starting point, where they are, what maybe they shouldn't be doing right now in the gym because that could flare them up, or and what can we do now that's really going to build confidence and allow them to kind of progress. So I think that's those are some really big points there. Otherwise, I don't think from virtual to in person or virtual, I don't think my assessment process has changed all too much. I can't put my hands on somebody. So I've had to use movement for buy-in, where in the past, like I can put my hands. I was actually just in New York a few weeks ago, and this was like a really good example. Like I can be with somebody and then I can do a massage, and then all of a sudden they get up and they feel better. And you can just like immediate like
Mhm.
buying, like, oh my God, this is great. I can't believe I feel like this. And I think touch is a really powerful way for us to connect with somebody and help them feel better. And I have to rely a whole lot more on movement. So I have to find ways in our sessions or in our assessments to start to play with movement, see how they're doing, and can I find something that does bring down their pain? And when you can do that, then I think that helps bring in that buy-in portion of things. So I've always done a lot of pre-test, post-test, but I think I have to rely on that a little bit more to figure out, is what I'm going to be doing or what I'm testing actually making a change, or is it reproducing symptoms? But also, I think it's one way that in a virtual environment, I can create that buy-in and say, hey, look, we can make your symptoms better by doing X, Y, and Z. Now we can take this, and these are your low hanging fruit. Do them daily, do them very frequently so we can start to bring down your pain, bring down your symptoms, so that once this initial few weeks is up, pain is better. We can now start to open the faucet and start to challenge you a little bit more and progress you. We can't really have you in this high pain state in a sense. So that's probably the bigger change there. Otherwise, and I think it's just a lot of the education, the way I look at things, that have mostly changed around like, oh, I assess this way or that way. Like I don't feel like that's changed. It's just been the overall how I'm kind of going about it and how I'm educating and putting it all together for somebody.
Yeah, I think the touch is always something that definitely comes up, and it's probably worth, you know, taking another couple seconds on it, especially for clinicians listening and clients who expect hands-on care, especially when you're in person with them. And I always have felt that I was using manual therapy more as a check-in on willingness to move. You know, how comfortable are with this joint? Just to be relaxed, maybe how much do you trust a lot of the movement around the joint? And you can always kind of get a feel on how apprehensive someone was, kind of by using your hands. So I did value that information. And now I think the way that I sort of look at a lot of the treatment of manual therapy, at least from my lens, is that it kind of fits more into the social aspect of care, maybe more than anything else. And if people aren't familiar with that idea, it's the biological, psychological, sociological aspects of all of us as human beings and how this impacts what we do as physical therapists, but really in maybe every facet of life. So we have biology, your body, your tissues, your psychology, how you process, perceive all of these things that are happening. And then sociology is just your environment, right? Your relationships. So I do think that this touch can bring connection, like you were saying. However, the boundary of it is, well, how do I bring touch into the virtual area? And what I've been doing a little bit more lately is trying to invite people to actually touch the area that hurts and just start like relaying information to me on what they feel. So it could be a back, a knee, a hip, but if they're laying down, I'm going to tell them, hey, just place your hand on there, and move it around. Maybe give a little bit of pressure, right? Do you notice like areas that might feel a little swollen? Do you notice areas that are maybe hot? Do you notice areas that are tender? Cool. Now go over on the other side. Just feel that out for me. And what's interesting is a lot of times, A, there's nothing to necessarily perceive, or B, people realize like, well, whatever's tender on this side is actually kind of
Mhm.
exactly the same tenderness on my other side. So I was so focused on that, but I never really thought to check in on the side that wasn't causing pain. So bringing in that manual therapy component with virtual stuff, I think has been a little bit more rewarding and has probably made at least some of the clients I've done with it recently more a part of that process right off the bat.
Mhm.
Because that's always their concern. Like, hey, I don't know what you're going to be able to do. You can't touch me. You can't move me. And I had a client yesterday who's been dealing with hip pain for 3 months, particularly with cross-legged sitting. And within about 10 minutes, we were pain-free cross-legged sitting. And she had gone to PT and all the other
Mhm.
stuff. And she was like, I'm so happy you told me to do virtual. I did not want to do this because I was like, this is going to be a waste of my time. And 10 minutes later, here I am sitting pain-free. So that was really cool. And by just giving people the tools to sort of like understand how to help themselves, I think is great. And when you mentioned how, or, kind of confirmed that the story is such a big part for you and the education piece is such a big part for you, I've been putting together a little course on, trying to help clinicians who are time crunched with assessments. And, I'm trying to play it a little bit more, by the book because I don't know who I'm speaking to, younger clinicians, older
Mhm.
clinicians. So I'm trying to give just like heuristics, like probably like what you and I use, it sounds like on like a lot of our virtual calls and our in-person things. But then only like a couple of tests for like each area that we actually have good data on, and these are tests for ruling in or ruling out diagnoses. And some of the most interesting things I've found out is that really two-thirds of the tests that we use are completely worthless. I
Mhm.
mean, literally do not move any
Right.
practical thought process forward, backwards, or anywhere in between. And really, one of the more interesting stats that I keep highlighting in the presentation is if you are about 80% sure of what's going on after the initial clinical encounter and the questions, actually doing special testing or your hands-on assessments isn't going to add to that.
Mhm.
And if anything, it's probably going to confuse you more because now you had like a fairly confident thought process. 80% is probably enough to move the needle where you and I could probably give some practical information to people. But then imagine trying to then go and confirm to get to 85 or 90 or 90, but really what you're doing is diluting your thinking and you're probably falling backwards even a little bit more.
Mhm.
So I am kind of going a little bit more upfront with clients now too, where, hey, look, by the sounds of this, this sounds like a tendon, this sounds like some joint irritation, and I kind of keep it broad. The good news is that it doesn't seem like it's getting worse or it's pretty stable. So really, I don't think we're going to find any value in a lot of hands-on assessments, but I do want to see how willing you're actually just able to move the
Sure.
joint that's hurting. And I do think that maybe will give us a couple of other ideas on how to help you at home and
Mhm.
in the gym and everywhere else. But have you thought about that with like special tests? Like, again, I know it's hard for probably, you to perform special tests, but like you said, you have to get movement buy-in with your clients. Are there go-to tests or movement strategies that you use sort of globally with everyone you look at, or are there just sort of like you kind of pick and choose based on the person?
Yeah, so I mean, I still use like the SFMA. So people, if you're not
Yeah,
a
perfect.
clinician, right, it's a certification we go through and just kind of gives you a helps us have a framework for how we're assessing. So, I do things holistically. I pretty much do a whole top down screen. The nice thing about this environment is without insurance and stuff like that, I don't have to be like, oh, I have to just focus on this area, right? I can look at everything. Someone gives me, and a lot of people have multiple areas of complaint. Maybe they have a big primary issue, but it allows me to, we can be focused here, but we can keep the whole big picture in mind here, especially when fitness is a big component of things. So I'll kind of go through that, but we're very similar in the fact that to me it is, sure, I would like to, if I can kind of rule in tendon versus nerve tissue versus what other tissue, right? But like I don't really know how much value if it was like, oh, is it a rotator cuff or is it a labral, right? Unless it's like a major big one where you're getting, I think the symptoms in itself would already lend you that you might want to push them towards imaging or going back to the doctor anyway, regardless of if they're like a full on tear and they're having painful with moving and the range of motion is limited. You're going to be like, well, maybe I can't even help this person here. Maybe they need to see their doctor first, right? So it doesn't matter if it's labrum or rotator cuff point at that, at that point. But that's kind of a longer winded way of coming back to, I look at, like, I ask a lot about their goals because when I'm going through movement, I'm looking at what can they do, what things are painful, what things make them feel better. And then I try to relate that as best as possible to what they're trying to do with their bodies. If they have shoulder pain and their goal is to get back to bench pressing, well, I know that they're going to need to be able to do certain things to get back to that.
Right.
So, can I break up the movements, break down their movements today and the movements they want to do? And can I start to match those things up and start to give their body the tools to be able to do those things? Can I start to reintegrate those patterns and load them in a fashion, even if it's easy to their perception, but maybe the tissues are a little sore because we're doing it, right? There's a little bit of pain being reproduced. So that's a good level for us to start. And we can reintroduce that stuff and get the tissues to adapt, right? It's all about, I think FRC, functional range conditioning, those certifications really changed my thought process, as
Yeah.
it's not just about what tissues are irritated and how can I treat pain, but it's more how can I start to load you and strengthen everything, right? The connective tissue, the muscles, whatever, and work you towards the things that you want to get back to. The sooner I can get to loading things, the better. And I think that if you look at an assessment and you took it in a vacuum, it's almost worthless
Right.
unless you have the person's goals, how it's impacting their life. And if you don't have a good starting point and a good ending point, you're really not going to have a journey to go on. You're just going to be throwing paint at a wall and hoping that you have something nice at the end of it. Kind of going back, I guess, how things have changed for me in a sense, as far as assessments go and my thought process goes, is probably the bigger ones. And again, I think it's movement. When we look at movement, we're looking at movement. We're looking at what's painful. We're looking at what makes you feel better. We're looking at what doesn't have any sort of impact on you whatsoever. And then that stuff allows us to make decisions in the future when you know what this person needs to accomplish or wants to.
Yeah, I'm glad that you brought up the SFMA because I think that's, again, part of the simplicity in the approach is trying to make decisions or get off point A. And that's always what the initial assessment, I think, does for us is how am I going to try to help guide this person in front of me, knowing that I probably won't get it right perfectly all the time on visit one. There's going to be adjustments, there's going to be tweaks. I know this person's going to flare. I know they're going to have good days. I know they're going to have bad days, but at least what's going to keep us on this path forward? And what I like about the SFMA, what you mentioned was we were always trying to deduce down really, was this a joint that needed to be, let's just keep it simple, stretched or mobilized, or was this a joint that needed to be a little bit more stiffer, stable, stronger, right? So I always sort of thought about those buckets when I'm working with people is, hey, are you loose or are you stiff? Right. And that was even like a simpler way to kind of bring it down. Not loose in the sense that you're falling apart, but hey, this joint moves really well. But when we do some force testing on it, or strength testing on it, we can see your symptoms return. So we know
Hmm.
that we need to create a better force capacity at this joint. Maybe not stretch it or pull on it or yank it or massage it because there doesn't seem to be any barriers there versus, like you said, hey, I know why you're having a little bit of trouble on the bench. Your arm or your shoulder just doesn't extend back as far as the other side. So we're hitting this roadblock. We see now instead of a force capacity thing, it's probably more of a force absorption sort of idea that the joint or the tissue just can't absorb this force. So we need to create space for things to move around. And I always liken it to, the highway system in New York City that, when traffic is moving, things are pretty calm and cool, but you shut down one lane, we have a bottleneck, and then that causes sort of
Yeah.
chaos throughout everywhere else, right? But the SFMA is interesting, and I know that we wanted to talk about, maybe some self-assessments people can do, and that might be some top-tier stuff. Could be really quick and easy to move through, give people a little bit of insight on how their necks and shoulders and hips and everything else are moving. So I don't know. Do you want to take me through a top tier, and I can demo it, or we could talk about it?
Well, let's talk about it. Maybe we can do a little bit, or maybe we can do a mini show that will be like YouTube specific. But I don't want people listening in that's not on YouTube to tend to feel like they're missing out completely. Yeah.
Yeah, if they're
So maybe
driving and
we'll do
starting to do
that.
cervical
We'll
rotation tests.
100% do that. We'll get that up at the same time as this podcast. So if you're listening, you'll have to go over YouTube if you want to see the assessment process. But I want to say two things before we kind of dive into this that I think is really worth touching on for anyone listening, clinician or non. Not getting it right on the first session, I think that's an important one. Sure, you come in, you see us, and you want answers, and we want answers, and we want to know where we're going. But every time that we have interaction everything is a reassessment, right? So when you send me videos online, or we have our next follow-up call, or whatever it is, we are, in essence, reassessing and reframing and making sure that either the initial hypothesis is, okay, hey, we're trending and we're tracking, or we're not, and we need to make some changes. So nothing needs to be perfect on session one, but we have all this other opportunity to continue to refine this process and make sure that we continue to move in a trajectory that's going to help this person move better, feel better, and move towards their goals. And then I love what you mentioned about the kind of highway system. We should get Moses Bernard on here because he's had one of the best quotes when he was originally on this podcast, when it was Fitness for the Fairways. And it was mobility work kind of gives you more roads to move through. And the strength training sets the foundation or makes those roads, stronger and gives you really that foundation. So, and that's really why that combination of the two is really important, right? So I don't know. That's always stuck with me ever since I've heard him say that. And it's just a simple analogy that kind of really drives home that point. So I think we'll have to get Moses on here. I'll
Yeah,
reach out
man,
to him
absolutely.
when
It
we
would be
hop
good.
on.
It'd be good to reconnect with him as well, for sure. And yeah, and that's such a simple idea, right? And I think that really kind of helps clinicians picture, maybe a little bit more of a thought process. It gives clients a little bit of insight on, hey, maybe it is worth doing a little bit of both. It probably usually is, but not feeling overwhelmed, I think, is going to be part of the opportunity of, you and I and that person to be like, hey, what's realistic for you to take our advice and actually use it? You can only have 10 minutes a day. Well, then maybe we do a little mix and match. It's mobility day is Monday, Wednesday, Friday, and your strength day is Tuesday, Thursday, or Tuesday, Saturday, right? But yeah, I think that's a nice little kind of way to categorize things. And it just sounds like, again, and maybe we've touched on this before, the biggest takeaway that I have is that over the years, our process has gotten simpler, not more complicated. And I think that where I am as a clinician now, when I do take continuing education or, whether it's online or in person, I appreciate the thoughts and the frameworks of other people. But at the same time, I'm always leaving like, well, I still don't think it has to be this complicated. So you take a couple pearls, maybe you apply them, right? And I think that's where that mixture of the SFMA top tier, maybe combined with some CARS work from FRC or controlled rotation work from FRC, and then a little bit more of that like deeper dive nuance where maybe we're blending both of them in terms of trying to figure out, is this stiff? Does this need stability? Or, is this something else? And if it's something else, should they be here?
Yeah.
Right. And I think that's, again, always the most important part of your assessment process. We're not going to get it 100% accurate. The tests do not do that. They just move us closer to a probability of being initially successful. But I think the biggest thing, and maybe we could save this for a different episode, is how I think too many clinicians and too many clients don't want to accept uncertainty in this process. And without accepting uncertainty, you're always going to be looking for the needle in the haystack. And it's going to take you a really long time to find that, in my opinion.
Yeah, no, I agree with those sentiments completely. So as we shift over to the assessment portion of things, or the self-assessment portion of things, I want to maybe talk about one more thing in this whole concept of, at the end of the day, if you couldn't do one of these things, right? Say, because these are things that we're making up here today. Does it matter? Does it not matter? So in my mind, when we're doing all these assessments, and this is why I think context is always kind of the king here, why we're looking at other factors like their goals and, whatever else that we can kind of piece together. But if you couldn't do some of these things and you didn't have pain, or you only felt a little stiff and you're able to do everything, at the end of the day, does it really matter? And maybe or maybe not. I think that's kind of my point here, is that at the end of the day, if you're going through an assessment process and maybe you weren't good on some things, it doesn't mean something's inherently wrong. And we need other things to start to tell us that we need to work on things, like you feel like you're moving backwards, or there's fear of movement, or pain is getting worse, or you're not able to do certain things again, like that you were able to do in the past to an extent that you want. And I think those are things that people need to keep in the back of their mind. So if someone does try this, I don't want them to be like, oh my goodness, I couldn't do X, Y, or Z, and the world's going to end, and make somebody more fearful of movement, especially if that's already part of the equation.
Right. No, well said. And I think all this stuff is screening, but screening doesn't typically work very well at an individual level. It usually works better at a population or team level. And I think that's some, again, nuances that we often forget. Yes, just because your neck doesn't turn as far to the right, it just might not turn as far to the right today. But start a walking program, start your squats again, start your deadlifts, check back in 12 weeks, and you might see your neck be totally symmetrical. And that's why I always love that idea of, just kind of helping people, like you said, with those low-hanging fruits. Are they meeting activity guidelines? How can they meet activity guidelines? What's important to them? And then let that process sort of, take hold, giving them that permission to move, letting them know it's safe to move. And then typically the body's a good learner. So if it gets these signals that it's safe to move, it's okay to move, and moving over and over again is just becoming part of your daily practice, well, then you're probably going to see change no matter what by just being consistent.
Yeah. Yep. So let's start here. Is there anything from a movement perspective that you feel is like every human being should be able to do this?
I mean, every human being should be able to do this. That's, maybe a little bit much. But again, I think for me, I don't have one of those, honestly. I think it really just comes down to, what does the person in front of me want to do? And then your hip flexion or your shoulder internal rotation or your, spinal mobility will matter more or less. If people just want to get back to walking or, their activities of daily living, they're not going to need maximum end range joint control.
Mm-hmm.
Walking is a very mid-range movement. If a mid-range movement, we can even make that argument at all. It's probably even less than a mid-range movement. So if people are just having pain with walking, and then I don't need to establish a million different assessments and give them a million drills to expand their highway system potentially, but I might have to help them with exposure programming. Maybe it's footwear. Yeah, sure. Maybe there's a little bit of a strength component at the hip or whatever. But I think honestly, I don't come into any assessment and I tell this to clients expecting them to have anything or wanting them to have anything more.
Mm-hmm.
The only thing that matters is their story. They had pain, or with this activity means very much to them. So then all of our conversation, at least for that initial assessment, is going to be based around that activity and that goal. And the findings that we come up with, in my opinion, or what I tell them, is should only move to serve that goal. And we can have conversations about, the other screen or the other, top tier assessments. Yeah, we can come back to your neck. But for right now, your neck is not limiting you from squatting. Your neck is not limiting you from walking. Your neck is not limiting you from running. So we'll put it on the shelf. Maybe when you start running or squatting or walking again, your neck starts moving better. We'll know that in a few weeks. We'll come back and recheck it. Right. But I think that's how I probably go about it is this is what you want to do. This is what you have. I think if we can make this a little bit better or more stable or more strong, that activity should be more approachable, more tolerable. And then if we have those two things together, then maybe we can make it a lot more consistent.
Good. Yeah. No, I like that. I think we're both very much the same way. Because even if being able to body weight squat or being able to touch your toes, those are all great movement patterns that a lot of people should be able to do. But there's just some people like for the squat. I mean, if you have certain bony, like your body is just built in certain ways, you might not be able to squat like other people. So I think it's unfair to pigeonhole people. And this is what I was saying before, right? Just because you couldn't squat or do a movement doesn't mean that something's wrong or that you need to make a change. And it requires a whole lot of context. So I think I don't really have too much more on top of this. I think we definitely do a little recording of us going through some movement
Let's
and
do it.
kind of how we do an assessment. And maybe that can be a little self-assessment tool that people can kind of go through so they can find it on YouTube. And maybe we can create a little page for it so people can just hit the link. We'll put in like the show notes and stuff like that too.
Love
But
it.
any other thoughts that you have here?
No, let's give them the assessment. And yeah, I think that was perfect.
All right. Well, take us
All right.
home.
Well, hopefully everybody makes their way over to the YouTube page, checks out our assessment. Joe, we love you. Listeners, we love you. Thank you for listening in to another episode. And please come back next week for more of the Beyond Pain podcast.